This week on the BackTable podcast.
There's, I think, a lot of excitement about what thulium fiber laser may be able to offer, particularly for dusting. And I think the idea is that the ability to really alter your power delivery, both the amount and sort of the way it's delivered, may help us to actually truly generate dust from a stone. So there's a lot of work being done now because obviously there's going to be some upper limit to this energy generation, and the concerns of maybe a downside to that energy generation in the collecting system in terms of potential damage to the urothelium with heat generation and things like that. So I think there's a lot more to come, and I think it's an exciting time for laser technology for stones.
Hello, everyone, and welcome back to the BackTable podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at backtable.com. This is Aditya Bagrodia as your host this week, and I'm very excited to introduce our guest today, Jodi Antonelli from UT Southwestern Department of Urology. Jodi is an associate professor here. She's an excellent clinician, tremendous surgeon. Patients love her, and really, really happy to have you. Jodi, how's the day going?
Hey, Aditya, doing great. Thank you so much for the invitation. I really appreciate it. I'm honored to be able to participate. So thank you.
Perfect. All right, Jodi. So, a lot to unpack today, and I thought that we would maybe just start out in the ER, where so much happens at our end as it pertains to stones. So, patients coming in concerned for renal colic, you're getting a call from the ED. What's the kind of basic, bare bones information that you want to hear here?
I'd like to know about the patient's vital signs. Do they have a temperature, tachycardia, hypotension? Did they do any preliminary blood work, specifically, with an interest in knowing their creatinine, their serum white blood cell count, and then a urinalysis? And then obviously, have they obtained imaging at that point? I'd go and see the patient myself, but getting a little bit more history as well from the provider who has seen them, kind of presenting symptoms, duration of the pain, if they have a history of stones previously, and do they kind of appear toxic, non-toxic? Is their pain controlled now? Are they tolerating PO?
Okay, yeah, clearly comprehensive history, physical review of information. And what are going to be your kind of dead ringers? This is a sick patient, time to do something, urgent decompression.
The sort of immediate triggers to want to intervene and do something to drain the kidney would be if the patient's febrile, if they're at all hemodynamically unstable. I mean, sometimes pain can give you tachycardia, but tachycardia coupled with hypotension certainly is worrisome. And then from the standpoint of kind of the objective lab work that you get, putting that in the context of the patient's presentation, an elevated white blood cell count in isolation sometimes could be just due to inflammation, but that coupled with a patient who may have some of those other signs, again, certainly heightens my concern. And then the urinalysis. So the urinalysis is tricky. Some of the parameters could be elevated in the setting of inflammation. Additionally, sometimes surprisingly, the urinalysis is not that impressive if the stone is truly obstructing. It sometimes doesn't look as bad as you would expect. But if you have a urinalysis with positive nitrite, that really kind of heightens my concern. Very severe gross hematuria, peridium, things that change the color of the urine can sometimes falsely, elevated nitrite that isn't actually a sign of infection, but a positive nitrite is worrisome. And then leukocyte esterase, I think, more often can be elevated with just pure inflammation. And then elevated white cells or presence of bacteria on a UA can also be worrisome.
Okay, so clearly these are going to have to be patient-specific indications, but a couple of scenarios that you touched on. So isolated leukocytosis, blood pressure, heart rate, temperature, all of that's kind of checking out, looking fine. Let's call it like a white blood cell count of 15. UA looks pretty good. Patient's reliable. Can you just give us kind of like a broad strokes of how you might manage that patient and say that the pain's been fairly well controlled with, medications in the ER?
Yeah, I mean, I think in that situation, if the patient, like you said, is reliable, they seem kind of hemodynamically stone cold stable. UA doesn't look particularly concerning. I mean, those people, I'd more suspect that that white count is due to inflammation. Those are people that obviously I'd want to have pretty close follow up back in the office with, but people that I would probably, at that point feel comfortable sending home to, to follow back up as an outpatient. I certainly would make sure that the ER not only sent a urinalysis, but sent a urine culture. Sometimes they won't do that if the urinalysis looks pretty benign. And then, plus minus on sending the person home on empiric antibiotics, I think it's you're never going to be faulted for that. But, in those situations, I think that elevation is typically more due to inflammation.
Perfect. And what about, a UA? Clearly we see ureteral stones with cystitis, maybe less of a concern for obstructive pyelonephritis.
The difficult patients to determine what to do aren't the people who come into the ER, febrile, tachycardic, hypotensive, and those are kind of a no-brainer. It's these patients who do come in, pretty, rock stable in terms of hemodynamics. They're not febrile, but the urinalysis, looks worrisome, even frankly worrisome for an infection. I mean, if the patient has an obstructing stone, I think, kind of looking at some other parts of that person's presentation and their history are important. I mean, if they're presenting, and it's not necessarily a significant amount of back pain that they're having, it's more kind of cystitis symptoms. If they don't have other comorbidities that would potentially cause immunosuppression, things like diabetes or on immunosuppressing medications. I mean, those are patients that perhaps I'd be more inclined to say it's more likely a cystitis as opposed to a obstructive pyelonephritis. I think this even comes up more often for me. Sometimes I'll have a patient that I'm working up for like an elective ureteroscopy and their urinalysis comes back positive, and it was a urinalysis that was just obtained, purely for a pre-op, evaluation. I mean, those people for sure, I'm not going to run off and stent. I would just put them on a course of antibiotics and sort of be treating their cystitis. I mean, the patient presenting to the ER, probably has had at least some degree of flank pain if they're presenting and unlikely just cystitis symptoms. And if that urinalysis is concerning, and there's a select few patients that, I think I would just treat with antibiotics, but the great majority, I would be inclined to stent. The issue is just, the stakes are so high. If you send a patient home who could have any component of obstructive pyelo, it's hard to justify that. So I'd say, erring on the side of caution and draining those patients is certainly, probably the way to go.
Absolutely. Yeah, I think we can all appreciate how quickly things can turn for a patient with obstructive pyelo. So the folks that are coming in, pretty sick, some tachycardia, hypertension, elevated lactate and so forth. Again, I know it's hard to bin people in one versus the other, but general preferences, nephrostomy tube versus stent.
Yeah, Dr. Pearl actually did a nice study in like the late 1990s and was essentially like a randomized trial where she, assigned folks to either a stent or nephrostomy tube, and they actually found, that there wasn't any significant difference in terms of, outcomes, normalization to being having a normal temperature, normalization of white count between those two groups. So I think, there is this thought that if a patient comes in more on the curve of sepsis, that a nephrostomy tube is really what's warranted. Her data would suggest otherwise. My kind of points that I use in deciding whether to go with a nephrostomy tube or a stent have a lot to do with the stone and the anatomy. If it's a extremely large ureteral stone, I mean, I'd say like over a centimeter and a half, and I'm concerned that I'm not going to be able to get a wire and a stent past it. Certainly, those patients I'd prefer having a nephrostomy tube. Anybody with any kind of difficult anatomy in the pelvis, bladder, a very large prostate is something to consider in older gentlemen. Just may be difficult to find the ureteral orifice. So, those patients for sure, I think do much better with the nephrostomy tube. So, the differences in sort of what you have to have a patient undergo to get either tube. So, general anesthesia versus some sort of sedation. I mean, if a patient is really hemodynamically unstable, it's theoretically you can have a nephrostomy tube without a general. Again, it's really a conversation that has to happen with IR and whoever anesthesia is at your facility as to how comfortable they are with doing that. That's also, I think, just the patient's stability, and a discussion with those groups is definitely something to undertake when you're deciding between which tube is better.
Yeah, I remember one time being on call and there's a lady that came in with a pretty dramatic presentation and we just did it, without general anesthesia. It just kind of had to be done and it worked out. Once upon a time, we used to do some stenting in clinic and, it was kind of full spectrum in terms of patient tolerability, but I suppose it's an option. Well, thanks for that, Jody. So fortunately, I would say that the majority of the patients aren't coming in, acutely septic, ill. They've got flank pain. They've gotten some medications in the emergency department. Can you kind of talk to us about your medication regimen, time frame for patients that you're going to counsel for a trial of passage?
Yeah, so I think it's important to get an idea from the patient. How long have they been having symptoms when they are presenting to the ER? Because that's sort of where your clock starts in terms of how long you want to attempt a trial of passage. So, I mean, the limited data that's out there, obviously, there's not a real ethical way to test this in humans. It's basically animal data. We try not to leave a stone in a location that could potentially be obstructing or partially obstructing for more than like 6 weeks. So typically, I'll make sure a patient has pain medication. There's a lot of emerging data now that NSAIDs actually may be better in terms of pain control than narcotics. So, if a patient has normal renal function, no contraindications to NSAIDs, I actually prefer like a ketorolac or diclofenac over narcotics. Sometimes I'll give the patient kind of a breakthrough narcotic prescription as well, like Tylenol 3 or tramadol, or occasionally hydrocodone, but recommend that the patient kind of uses the NSAIDs as their first line. And then there's a lot of data, mixed data, and I think a lot of differing opinions around the globe about medical expulsive therapy. So the use of alpha blockers for promoting stone passage. The U.S. versus Europe, and specifically the U.K., I think have very different thoughts on what should be done. So there was a large trial, probably 2015, that was conducted in the UK, and they had a very different outcome measure than many of the other studies that were done. It was basically not a radiographic outcome in terms of stone passage, but lack of need of intervention. But based on that trial, I think the UK and most of Europe are less inclined to prescribe alpha blockers for medical expulsive therapy. I think in the US, it's still recommended in our AUA guidelines, specifically for larger distal stones. The data is greatest there. So, I think prescribing a patient an alpha blocker is something that, even if it's a proximal stone, I tend to do. My thought is that potentially some of these studies, may not actually be powered to really show a difference that maybe matters clinically. I mean, if taking a pretty well-tolerated medication even has like a 1% chance of preventing me from needing a surgery and a stent, I think it's worth it. Certainly for larger distal stones, like over 5 millimeters distally, I would definitely recommend an alpha blocker, but I'm usually inclined to prescribe it for any ureteral stone. And then, plus minus on antiemetics, depending on how the patient is feeling.
Steroids at all? Is that a part of your passage regimen?
Yeah, I don't typically for the time during a trial of passage.
Okay. Okay. So, I think historically it was kind of this 1 minus stone size formula where you get about a 90% chance with a 1 millimeter stone, 80% with a 2 millimeter. Of course, there's going to be patient anatomy specific, but are there patients when they start approaching a certain threshold that you're like, yeah, this is going to be something that requires surgery, and go ahead and start that process?
Yeah, it's a good question. I mean, the AUA guidelines say a trial of passage is reasonable up to a centimeter. I mean, obviously, your success, particularly if you haven't passed a number of stones before, of passing a 1 centimeter stone is going to be pretty darn low, like below 10%. I usually, once the size gets over 5 millimeters, you do sort of get progressively, less and less likely that you're going to pass that stone. Certainly getting over 6, 7 millimeters, I'll, in a patient who does not have a history of repeated stone passages previously, I'll talk with the patient about probably limited utility and waiting, and perhaps better to just go forward with planning a surgery for removal.
And do you send these patients home with strainers or get KUBs at the time of presentation to see if they're radio opaque?
Yeah, unfortunately, many of the patients, are seen in the ER, and then the first time that I actually, get to interact with them will be in the clinic. But I think your first contact with that patient, it's definitely helpful to get a KUB. I mean, it just helps a little bit about potential stone type, allows you to know whether you can follow that patient, to determine if they've passed it with a KUB as opposed to a CT, which obviously is a lot less radiation, less cost. And then I think a strainer is always good to give a patient.
Okay, couple of, scenarios that we sometimes come across. Solitary kidney, still making urine, ureteral stone. Where does that kind of sit in terms of anxiety provoking?
I'd say pretty high. I think if you have, again, a very reliable patient, I don't think you have to, run off and deal with the patient immediately. However, I think if you were not going to, the patient better be somebody that is incredibly reliable. I mean, if it's a very, very small stone, 2 millimeters or something, that person, again, is incredibly reliable. You've checked a serum creatinine and it's normal. You could potentially attempt a trial of passage in them. But I think solitary kidneys or bilateral ureteral stones are certainly situations where, erring on the side of caution and, taking those patients to the OR fairly urgently is certainly prudent.
Okay. And if they haven't caught a stone in the strainer or directly observed the passage of the stone, do you routinely get a CT scan or a KUB if it was in fact documented to be radiopaque before surgery?
Yeah, absolutely. I mean, I think, just going on symptoms, you will absolutely, run the risk that that stone is still there in the ureter. And, over time, a stone can actually just slowly grow. And, if a kidney is sort of put in a situation, I think, where there's a decreased drainage over a long period of time, sometimes it's not a symptomatic thing. And so I think you want to be able to document that stone has in fact passed. If the patient comes to you, several weeks later, just hasn't had pain at all. So again, it's nice if you have the KUB, you can get another KUB and see, even if I have a KUB that shows the stone is radio opaque, I will typically, and I get a repeat KUB and it shows that it's no longer there. I'll often also get an ultrasound. If the original imaging was a CT that showed hydronephrosis, I like to be able to document resolution of that hydronephrosis with the ultrasound. I think we all want to limit radiation exposure as much as possible. So if you can avoid a CT as repeat imaging and get the majority of your information through KUB and ultrasound, that's certainly the best way to go. Some situations, either due to patient body habitus, or the stone not being radio opaque, then in those situations, getting a repeat CT, I think, is certainly what's recommended. If it's a distal stone, sometimes I'll just do a CT of the pelvis to avoid as much radiation.
Okay. So, a non-toxic patient, trial of passage, repeat imaging in about maybe 3 to 6 weeks, I guess, depending on stone size, pain, etc. Can you describe what your standard preoperative antibiotics are, and maybe just kind of walk us through, like a garden variety ureteroscopy in your hands?
Sure. So if I have a patient that I, see has failed a trial of passage, I like to make sure that they have at least a urinalysis or a urine culture, about 2 weeks to a week before surgery. I mean, the AUA guidelines would say at least a urinalysis. And then I don't, put patients on antibiotics preoperatively if they have a negative culture. If they have, like I mentioned earlier, patient gets a pre-op culture, they're asymptomatic and it comes back positive, I'll start that patient on antibiotics. And ideally, I mean, there's, no right answer with this, but I usually typically make sure the patient is on an antibiotic at least 5 to 7 days, culture specific, before proceeding. If I have a patient who's had a history of recurrent UTIs and maybe that, very last culture prior to surgery is negative, but, I'm concerned that they could have issues with bacteria that's present there, I have a low threshold to put those people on antibiotics preoperatively, maybe 3 to 5 days. In terms of kind of perioperative antibiotics at the time of surgery, I certainly do give typically a cephalosporin if they don't have any kind of issue with allergy at the time of surgery. And then I don't prescribe antibiotics beyond that. The AUA guidelines would say that perioperative dose is sufficient. And so, again, unless the patient has a history of recurrent UTIs or, issues with infections, then I won't prescribe an antibiotic postoperatively. And then, just in terms of the ureteroscopy itself, we actually instituted a kind of a multimodal pathway with the help of anesthesia here to kind of decrease the narcotic requirement around the time of surgery, and also to sort of have the patient hopefully, waking up from surgery and ultimately being discharged with their pain under as good a control as possible. So, they're not leaving the hospital kind of having to play catch up. And that pathway has been, incredibly helpful. So, utilizing things other than narcotics, things like NSAIDs, gabapentin, IV Tylenol. It's really, we've looked at this and it's really decreased morphine equivalent usage in the PACU. It's decreased patient calls in the time between surgery and stent removal. So that has really been a successful thing for us here. In terms of the surgery itself, the ureteroscopy itself, typically, the first step, putting in the cystoscope. I always, talk with the residents about the importance of doing a really thorough cystoscopy. You don't want to be the person who misses a bladder tumor that somebody diagnoses a couple months later. So, getting a good look around the bladder, being sure that there's nothing that looks suspicious there, and then, placing a guide wire. I typically start with a PTFE 035 wire. I know, many people will start with a hybrid wire that has a hydrophilic tip. Sometimes will help get around stones in the ureter. And then I do use a device called an 810 dilator. I think it's incredibly helpful for dilating the ureter and then gives you the ability to place a second wire.
Couple of quick questions, Jody. What about large prostates? UOs are kind of tricky to see. Any kind of tips and tricks on that one?
I mean, sometimes a 70-degree lens could help. It could be very difficult to pass a wire through there, but at least give you an idea, where the UO could be. A flexible cystoscope is also sometimes something that could be helpful. The real tricky thing is the more you look, sometimes you end up really stirring up bleeding, and then the visibility just gets more and more difficult. But the other thing, like a methylene blue or indecidin green, sometimes will allow you to kind of get an idea where efflux is happening so that you can direct your wire at that spot.
Speaking of bleeding, patients on anticoagulation, is that something, clearly you want to get cardiac clearance, but are you okay, comfortable with Plavix, Coumadin, next generation antiplatelet medications?
Yeah, it's a good question. For ureteroscopy, yes. And they've published a number of series that, ureteroscopy on aspirin or other anticoagulation medication, can be done safely. You're not cutting the patient anywhere. So I think, the risk to the patient coming off those medications is probably greater than any risk of significant hematuria. I do counsel patients after, that they may have more hematuria than the average patient, and certainly to, have a low threshold to call us if they're passing large clots or anything like that. I have not had that issue in, a number of patients that I've operated on with essentially, all anticoagulation or antiplatelet agents. Now, PCNL is a different story. So for PCNL, there have been a number of studies on doing PCNL on aspirin, 81 milligram aspirin, and I do that and have had good success, without any significant issues with bleeding. But aspirin 325 or pretty much any other anticoagulation agents, I don't do PCNLs, and I'd say most people around the country feel that way.
And do you always shoot a retrograde when you do your ureteroscopy, or is it case by case?
Yeah, case by case. I know there are lots of folks who do, and I certainly don't think it's wrong, and gives you a nice roadmap of things. But I typically don't do it unless I'm having difficulty getting a wire to traverse the direction, or the pathway that I anticipate the ureter to be going.
Okay. So you talked about getting your first wire up. What about, you get that wire up and, not frank pus, but it looks a little cloudy, a little turbid. Urine culture preoperatively and UA were clear. Does that put you on high alert, or?
Yeah, it's tough. Sometimes it's turbid and, turbid from infection and turbid from just stagnant urine could be, difficult to discern. So if it really, stuff's coming out around the UO that looks at all worrisome, I would put an open-ended 5 French catheter up, try and get it up into the renal pelvis, pull out the wire and really aspirate some urine from up there and try to get a better look. I mean, if it is anything that looks like frank purulent urine, for sure at that point I would stop and just stent the patient. If it's just a darker red or some debris, again, on a case by case basis, but in a patient with, incredibly low risk in my mind of infection, I would proceed at that point. with the ureteroscopy.
Okay, great, Jody. So, you talked about getting your first wire up. Let's just say you're having a hard time getting it past the stone. Some options that typically have worked, and I've heard of slurries, a combination of lube and contrast, various wires. Or can you kind of talk us through your algorithm for that clinical scenario?
Yeah. First thing I will do is pass a 5 French open-ended ureteral catheter up, to the point of the stone, and sometimes just having that additional, rigidity or that backing at that point could help. I'll take out the standard, double floppy tip PTFE wire that I use, and I'll try instead a hydrophilic wire, like it's usually just a pure hydrophilic wire, occasionally a hybrid wire. I think injecting at least contrast, and I actually do sometimes do this slurry with, a little bit of lubrication and saline. Sometimes if you can just get a little bit of contrast or some of that slurry to get past the stone, number one, you'll sort of see the path where the ureter goes more proximally, and sometimes that could be helpful. And I think sometimes it also does just help that hydrophilic wire to get by. So, that's kind of my two tools, the 5 French open-ended catheter and the hydrophilic wire, just, gently trying repeatedly to see if there's some angle or some corner I can catch where that angled glide wire will get past the stone.
Okay, and say you've really kind of spent your time, nothing's getting by. What do you recommend at that point?
So, in those situations, I think it depends on your comfort level. I mean, if, there's certainly no one would fault you for, if, again, depending on the scenario, having the patient have a nephrostomy tube placed. The other, and dealing with this at a later date. The other option, that I will do is I'll basically put back in that double floppy wire. I'll coil it under the stone. I'll reintroduce my 810 dilator and coil a second wire under the stone, and then I'll advance an access sheath up distal to the stone. You obviously don't have a wire past the stone, and in those situations, it could be a little bit hair raising if the stone is really impacted, because you just don't want to, kind of lose your lumen. But lasering the stone to sort of get a window, where you can get a sense for where the remainder of the ureter goes proximally, and then as soon as you see, any sort of light at the end of the tunnel, getting a wire up past the stone. And then at that point, you have a wire through the access sheath. So you're not going to be able to introduce a ureteroscope back through the access sheath. So then take out the access sheath, get a second wire back in, and then put your access sheath back up to continue treating the stone.
Right. And what about semi-rigid ureteroscopes, just trying to get in and, create some of a channel? Do you recommend that at all?
Yeah, I mean, if it's, certainly if it's a distal stone, in a woman, you could get a semi-rigid ureteroscope fairly far up. I think sometimes those scopes give you a little bit more, again, rigidity. There's obviously less degrees of freedom, and so kind of gets you to where the stone is a little bit easier. So, I think that that's certainly an option. I think, at least getting a wire coiled under the stone kind of helps straighten the ureter, whether you do semi-rigid or flexible ureteroscopy.
And what if you can't get your scope in, whether that's you've done your 810 dilator, whether it's a semi-rigid or a flexible, kind of some options for navigating the UO, or when you kind of say, all right, let's get a stent in and, come back and fight this battle another day.
Yeah, I think tight ureters are certainly a challenge. For in my hands, or my opinion, if the ureter appears to be tight, pretty much distal to the pelvic inlet, like iliac vessels and distal, and I'm sure that the stone is not in that location in the ureter. The stone is more proximal. I'll balloon dilate the ureter. So I mean, at this point, if I've tried the 810 dilator, and it's pretty tight, I've shot a retrograde, and I have an idea sort of, where this narrowing is, and I'm confident that the stone again is not in that area, then balloon dilation in the distal ureter I'm comfortable with. I mean, as the ureter, tunnels through sort of the intramural part of the ureter, it's 3 layers, so I think it tolerates balloon dilation better with a lower chance of any kind of issues with stricture. And there have been series published on balloon dilation throughout the entire ureter with success, and there are some folks who feel comfortable with that. I don't like to balloon dilate the proximal ureter just because my fear at that point, it's two layers, it's thinner, and I just worry about a higher likelihood of stricture in those locations.
Okay. And is that a 4 centimeter balloon? What French and what pressure do you typically go with when you're dilating?
So I usually do a 15 French 4 centimeter balloon, and I usually will go to 14 atmospheres, and I go slowly. I start at 2, and then wait a couple seconds, go to 4. I don't just like slam it up to 14 atmospheres immediately. And then sometimes you see a waist, sometimes you don't. Certainly, if you do see a waist, you can go up to, those balloons are rated to 20, so you could go up a little bit higher if you need to get that waist to open. But usually at 14 atmospheres, I've had pretty good success with opening those areas in the ureter.
When is it that you stent and get out and come back?
Yeah, so it's tricky. I mean, my practice, I prefer to use an access sheath, and I like to actually fragment and extract. So without an access sheath, that's obviously a challenge. So for me, if I can't get our smallest diameter access sheath up, a 9.5, 11.5 French, then I sort of try to decide in my mind, what I think would be best. So one option is to just put the ureteroscope up without an access sheath and dust the stone. If I feel like the stone is small enough, if the situation with the patient, I'm comfortable with dusting as opposing to fragment extraction, then I'll do that. I tend to feel like dilating them with a stent for a week and bringing them back, and being able to extract the fragments like I typically do is often the better approach. I'm just sort of happier with that. So if I have difficulty getting that 9.5, 11.5 sheath safely in, then I'll typically stent and bring them back.
And what are your typical dusting settings, Jody?
So, it depends on the laser that is available. But, as a kind of a general rule, if you're dusting, you essentially want a very low energy because you just want to be like chipping off little pieces, and a very high rate. So, if I have a 100-watt laser, I'll do zero point 0.2 joules and 50 hertz. Sometimes, doing a zero point 0.4 joule and 50 hertz will get you to move through it a little bit faster. The issue is you end up with a little bit larger, chunks of quote unquote dust.
And what about if you're fragmenting? What's your kind of workhorse laser settings?
So again, depending on the laser that I have, but typically, 0.8 and 8 is sort of my starting point, and then depending on the hardness of the stone, I'll sometimes modify things from there. Sometimes, if it's a real dense hard stone, I'll go up to 1 and 10. If I have a 100-watt laser, sometimes doing a 0.6 and 20, or even a zero point 0.4 and 50, depending on the properties of the stone, sometimes will generate, more fragments than dust, and it kind of moves through it a little bit quicker than the 0.8 and 8.
Okay. And so you mentioned for your second wire, you typically use an 810 dilator. Any strong opinions on dual lumen introducers versus serial dilators?
Yeah, I think the issue I have with dual lumens is just sometimes if the ureter is a little bit tighter, you have a very short distance of tapering, where you're kind of jumping to the 10 French pretty quickly, and so oftentimes it won't go in as easily. So the advantage I see with the 810 is that you really get the 8 French dilation and then the 10, so it's just sort of a little more gentle sequential dilation, which I like.
Makes sense. So, access sheets, you mentioned them several times that those are kind of your preferred way to go. What are your kind of workhorses in terms of inner outer diameter? Any ones that you find to be particularly effective in your hands?
Yeah, just within the last, I don't know, I'd say maybe 3 years, I've sort of changed my go-to sheath size. So, prior to that, if I could get it to go, I would do a 12/14 French. I transitioned to a 10/12 French more recently. I mean, if a stone is over a centimeter, then, I'll try for the 12/14 because obviously the larger diameter sheath I can get in, the larger fragments I can extract, and the more efficiently I can do that. But I've been really impressed with the ability to extract fragments through the 12 French sheath. I mean, it's 2 French smaller, but it doesn't limit really my ability to extract as much as I expected. And I do find that the appearance of the ureter on the way out is a lot more favorable. Sometimes you get that real tight kind of pale appearance with larger ureteral access sheaths, and that the 10/12, the ureter just sort of looks less stretched.
And is there any impact on the type of scopes you can get up?
Yeah, that's a great question. So the newer generation digital ureteroscopes and the disposable ureteroscopes will fit through a 10-12 access sheath. Older generation digital ureteroscopes will not. So, for example, Olympus has a V and a V2. The V is the older generation that won't fit through a 10-12. So, certainly your availability of scopes is something to consider with your access sheath size.
And for you, is it always digital preferred? Bigger is better?
Yeah, it's a good question. I mean, no, not necessarily. The one advantage I find with the fiber optic scope is actually a little bit more flexion. So, sometimes a stone in a very dependent lower pole calyx, I find an advantage to the fiber optic scope. Obviously, you're trading off some clarity of image to a few more degrees of flexion, which sometimes those few degrees can make all the difference in the case. The other thing that I find, sometimes I'll choose one scope over another is where the laser or the basket comes out. If you're looking at the screen and you think of it like a clock face, some companies the laser comes out 9 o'clock, some companies it comes out 3 o'clock, and we're fortunate here to have several different options to choose from. So sometimes going up and determining what approach will allow me to get to the stone in terms of where that equipment it comes out is the decision point for me on which scope to use.
Got it. Yeah, I certainly would say that, sometimes when we're taking a look up for upper tract tumors, I think that the P6 is a pretty decent option if you're not planning on using a access sheath in my hands and in that clinical scenario.
Yes, I've been very impressed. I mean, even though it's a fiber optic scope, the visibility with that particular scope is excellent, and it's very atraumatic. It's tiny, and allows you to get good flow. It's a great scope.
And speaking of flow, handheld pressure irrigator versus pressure bags.
Great question. I think the irrigation in a case could really make or break you. And I actually think that the most important job in a ureteroscopy is the person who, if you are doing handheld irrigation, is the person holding that irrigator. I mean, they could probably cause close to as much damage as anybody can during that procedure. So, I think if you are going to do handheld irrigation, it has great advantages. Allows you to sort of modify, you can prevent blowing around pieces if you're grabbing things. You can use a little bit more irrigation to, see things or get through areas. But you really have to, I think, be careful who's holding that irrigator and are they understanding sort of the power that they have. So, during most cases, if I'm operating with a fellow or resident, I actually prefer to be holding the irrigation, because if somebody irrigates too hard and say an infundibulum, a calyx with a very narrow infundibulum without good outflow, you can cause a significant amount of bleeding and then difficulty actually, with visibility for the remainder of the case. And we don't obviously routinely image people after ureteroscopy with CTs, but handheld irrigation that's too powerful without good outflow can actually cause pretty significant subcapsular hematomas and things like that. So I think pressurized irrigation is probably obviously a little bit less modifications that you're able to make to it, but in some ways could potentially be a bit safer than handheld irrigation if you don't have the right person doing it.
Okay, good. I think some good things to consider there. So, we kind of talked again about a typical, you've got two wires up, you've got an access sheath up, and we've lasered away basketing fragments. What are your kind of go-to baskets and pros and cons of some of the various ones that exist?
Yeah, I mean, my favorite tool, I would say, disposable tool for ureteroscopy is a basket or grasper made by Cook called the N Gauge. Boston Scientific has a similar one called Dakota, and it is almost like a three-dimensional triangle. It's kind of like a fish mouth where the front of it is open. I think for ureteroscopy, it offers two advantages. One, you're typically grabbing fragments that are in front of you. So having the grasper, the basket open in the front really helps you to, advance the basket out, grab something and retract. You're not having to catch the fragments on the side of a basket. The other nice thing I think with those designs is it allows you to disengage the basket easier than, with a like a zero tip basket or an end circle basket that tends to be more oval shaped. So if you pull out a fragment that's too large and you're sort of stuck in the ureter, I think it's easier to disengage those triangular baskets like an N gauge.
Yeah, I know that's something we use fairly extensively in training, and I think my ability to estimate a stone size is pretty terrible. Anytime I use the 1 centimeter basket or so forth, I was a little over ambitious. So I feel like the N gauge does kind of keep you honest. So you mentioned that you prefer basket retrieval versus dusting. I imagine there are scenarios that we come across where dusting may be, preferred. Maybe a further word about that, Jody?
Yes, I would say this is a great debate in endourology. And any meeting you go to, this is always a plenary topic. So it is something that is certainly, one approach has not been proven to be superior to the other. And to be honest, I think the right answer is a combination of using both approaches in your practice, and sometimes a combination of both approaches in a single case. Certainly if I have a larger stone that I'm trying to treat ureteroscopically, 1.5 centimeters, for example, I mean, it's pretty ridiculous to try to purely fragment that stone and extract it. I mean, you will be there a long time. And actually, we've looked at success rates of extraction for stones over 1 centimeter, and despite the most meticulous attempts, it's about 35% that you aren't, getting a patient completely stone free with pure fragment extraction with these larger stones. So I tend to do more of a combination dusting, fragmenting approach for those larger stones. Again, like centimeter, 1.5 centimeters, trying to sort of dust it down and then extract fragments. I think the biggest issue I have with the concept of dusting, and I think many people also feel this way, is that our laser technology hasn't really gotten us to a point where we really generate true dust. I mean, I think we just generate small fragments, and so the concern is, are those small fragments going to act as a nidus to cause a recurrence of a stone in a shorter amount of time? So that's something that has never been proven, and something that there's a multi-center group called the EDGE Consortium that's sort of looking at that. There's been some short-term studies that have been published looking at the differences between dusting and fragmenting, and I think that these groups are looking to follow these patients longer term, and I think that data will be really interesting. And then the advantages of dusting obviously have been shown to be potentially shorter OR times, less cost because you're not opening as many disposable items. But the issue is you're potentially leaving that patient with some higher likelihood of stones or fragments or dust left that maybe won't pass out of the collecting system like we expect it will. The other issue with dusting too is that sometimes if you have a larger stone and it generates so much dust, it's hard to see the bigger pieces that may be there within the dust. Fragmenting does have a higher stone free rate, but it's not perfect. And the other issue with fragmenting is it does have a higher cost. You're opening more items, and you're usually in the operating room longer to perform that technique.
So you mentioned disposables and cost. Disposable ureteroscopes coming through the pipeline. What do you think? Do you use those in your practice? Is this going to be something that's going to be prime time in the next decade or so?
I think it's certainly something that is becoming more and more, available. And I think depending on your practice situation could potentially make a lot of sense. They've looked at cost analyses of, disposables versus the, reusables and maintenance costs and repair costs and things like that. I mean, I think there's some sweet spot in terms of volume where probably disposables make more sense. I have used disposable ureteroscopes. I've been incredibly impressed with the digital quality image that you get. It's amazing considering that you throw the item away. So yeah, I don't use it routinely in my practice, but I think there are certain scenarios where you can argue if you have the availability to use it, it may be better. Lower pole stones where you're concerned potentially you're going to really max out your reusable scope and could potentially damage or break it. Better to use a disposable scope in those situations. A patient with numerous ESBL or multi-drug resistant urinary organisms, maybe those people are better off with a disposable scope rather than a reusable scope. There's been some studies to show our sterilization isn't always, at what we expect it to be. So those are probably the two scenarios where I think disposable scopes have their best benefit. But I certainly think, as your go-to scope, it's also a very feasible, good option, particularly if the volume of your ureteroscopy that you do sort of fits in the cost scheme.
So for some of these lower pole stones, tough to access, what are some of the things that you'll do to make it a little bit of an easier affair?
I think looking at the stone and the size of the infundibulum are key. If you think you can get that stone out of the lower pole through the infundibulum without getting stuck, I try to do that. I think whether you're going to dust or fragment, it's hard to get stuff out of the lower pole, and it's hard for a patient to pass anything out of the lower pole just because of the dependence of that area. So the one concern with that though is you really if a stone at all looks like it'll be too large to get out of there, you don't want to get a basket stuck on the stone in the lower pole. That's a real tough spot to be in. So, I had mentioned the N gauge as a go-to fragment extractor. If I am going to displace a stone from the lower pole to the upper pole or the renal pelvis, in those situations, I actually tend to use like a more oval shaped basket, like an N circle. I think it's easier to sort of just catch those stones sort of from the side and bring them up. But if possible, I try to displace the entire stone. If it looks like it's too large to bring out, then I'll fragment it as minimally as possible in the lower pole, and then bring up the fragments to the upper pole, and then further either dust or fragment in that more favorable location.
Okay. And when you're going back and forth between basketing and lasers, do you use a laser and a basket in the same port, or are you typically switching those instruments in and out?
I do use them in the same port. That's another thing I started to do a couple years ago, and I think it's really helped, decrease the amount of time. So, none of the lasers that I'm aware of on the market come in any sort of, reel that's able to contain the laser well once it's out of the scope. And so, you spend so much time pulling the laser out, wrapping it up under a towel or a mosquito or something, and just that all that back and forth between laser and basket, I think is some of what increases the operative time with fragmentation. So I've found that a UraSeal device or a SureSeal device can accommodate a 270 micron laser fiber and a grasper or a basket. The 1.8 French graspers or baskets and the 270 lasers tend to fit in there together better than like a 2.4 French. Those can be a little bit more drag when you're trying to move the basket and the laser back and forth, and it could also decrease your irrigation flow. But the combination of a 1.8 French, like an N gauge, and a 270 laser, I've found excellent flow and really nice maneuverability. So I'll pull the basket back into the scope, I'll laser, and then once I'm happy with the fragments, pull the laser back into the scope, make sure you're no longer, on ready, you're no longer pressing the pedal, and then advance the basket out and extract. Sometimes you extract something too large and you can pass the laser out and whittle it down a little bit and get it out without having to disengage the basket. So I think it really is a huge time saver as long as you have sizing that makes sense for maneuverability.
Okay. And you'd mentioned, the lasers maybe aren't quite there to be true dusting lasers. You hear at meetings and so forth that there's some pretty exciting things coming through, Moses lasers, thulium lasers. Have you used any of those? Do you have any experience on that front?
Great question. Yes, yes. So, you're exactly right. I mean, I think laser technology really hadn't changed a whole lot. And then within the last couple of years, there's been kind of some tremendous changes and improvements. So, high power holmium laser, like 120-watt lasers. And then with the addition of these kind of pulse modulation and pulse length variations that could be delivered. Speaking specifically to Moses, I mean, not only can you alter the pulse length, but Moses is a specific technology Luminous has that it's kind of you're also modulating the pulse delivery. So you're essentially trying to kind of modulate that energy so that you get a combination of stone stabilization and improved delivery of energy. Other companies, have similar different terms that they've coined, but for this pulse modulation, holmium laser technology kind of has a ceiling in terms of where you can go with energy generation. Some of it has to do with the fact that the cooling system that has to be in place, for that laser to function. So sort of the next generation that's come along in the last year or two is thulium fiber laser. And that laser kind of works in an entirely different way, but it allows for much higher energy generation, and the cooling system within it is very different, and requires much less space. So there's, I think, a lot of excitement about what thulium fiber laser may be able to offer, particularly for dusting. And I think the idea is that the ability to really alter your power delivery delivery, both the amount and sort of the way it's delivered may help us to actually truly generate dust from a stone. So, there's a lot of work being done now because obviously there's going to be some upper limit to this energy generation and, the concerns of maybe a downside to that energy generation in the collecting system in terms of potential damage to the urothelium with heat generation and things like that. So I think there's a lot more to come, and I think it's an exciting time for laser technology for stones.
Got it. All right. So let's say, we've done our combination of dusting, fragmenting, extraction. We've taken a nice tour of the kidney. We feel that things are pretty much cleared out. Just walk us through maybe, how you remove your access sheaths and potentially what you would do if you identified like a little perf linear tear on your way out.
Yes, great question. So certainly, always as you're exiting the kidney, withdrawing the access sheath under vision and examining the ureter is key. So, Dr. Traxler published a paper that sort of graded ureteral injury, and there was actually a follow-up to that paper published a few years ago looking at what were the outcomes of these patients who had these different grades of ureteral injury. And they essentially found even at the highest grade of ureteral injury, not a complete avulsion, but, a tear of the ureter to fat, there was only a 1% chance of an ultimate stricture later. So there's no question that, there's obviously concern when you see a tear within the ureter, but recognizing that, obviously, absolutely stenting the patient in those situations, and then there's nobody knows the exact length of time that these stents should be in, but I'd say if it is a tear of the urothelium where you're seeing fat, I'll typically leave a stent for at least 4 weeks to allow that area to heal.
Okay. And what about, like a perf? Maybe you get up, things look a little off. You shoot a retrograde and you've got some significant extrav. Is that a get out and come back another day or?
It's a good question. I mean, if there's a lot of there's a lot of reasons why you can have extravasation. So sometimes it's merely the wire poking through the the papilla that can cause that. I mean, if